Discovered by Thomas Benton Cooley and Perley back in 1925, thalassemia was previously known as Mediterranean anemia, as it was first found among the people around the Mediterranean Sea. It was first thought that thalassemia is a chronic, progressive, and life-threatening disease of childhood, as the researcher hypothesized that the red blood cell destruction are very severe, to which none of anti-anemic therapies employed at the time was effective. Eventually, in 1964, the researcher has discerned thalassemia as a type of hereditary blood disorder, but a mitigated extent, as the disorder is found to be non-life-threatening. Fundamentally, thalassemia is marked by the abnormality in the structure or amount of hemoglobin, which is noted as a type of protein in red blood cells that are responsible for carrying oxygen to the body tissue. Therefore, in response to this disorder, the body would destroy the red blood cell, leading to anemia. Essentially, there are two main types of thalassemia, which are distinguished by the type of globin protein of the hemoglobin being affected. Hemoglobin structure is composed of four heme groups, noted as alpha 1, alpha 2, beta 1 and beta 2, which are surrounded by a globin group. Therefore, when at least one of alpha globin gene is missing or has undergone a mutation, the thalassemia disorder will be categorized as alpha thalassemia. Meanwhile, when any of the beta globin genes are affected, the disorder will be known as beta thalassemia or Cooley anemias. It should be noted that any imbalance of the globin chain will result in hemolysis and impairment of erythropoiesis. To further elaborate, both alpha and beta thalassemia has a major and minor subgroup. When a person has inherited the defected genes from both parents, the individual will develop a thalassemia major. Meanwhile, when a person has only received the faulty genes from one parent, they will acquire thalassemia minor and may also be recognized as a thalassemia carrier. Generally, thalassemia is usually diagnosed during early childhood, as the signs and the symptoms often occur within the first 2 years of life. During the diagnosis, the doctor will look for symptoms such as dark urine, facial bone deformities, fatigue, growth stunt, shortness of breath, jaundice, as well as red blood cell abnormalities to identify a person with thalassemia. However, a child with the minor form of thalassemia may have small red blood cells without presenting any visible symptoms. Nevertheless, it is also noted that the symptoms also tend to show up later in childhood or adolescence. Moving on, the treatment for thalassemia would depend on the type and the severity of the disorder. Essentially, the carrier will present mild or no symptom, does not require any form of treatment. Meanwhile, those who are living with the moderate and severe form of thalassemia may be prescribed with the three standard treatment by the doctor, which include blood transfusion, iron chelatin therapy, and folic acid supplements. Other possible yet less often used treatments for thalassemia also include blood and marrow stem cell transplantation, as well as the modification of the hemoglobin gene. As thalassemia could only be cured through stem cell transplantation, to which not all of the sufferers are suited for the risky procedure due to possible incompatibility with the donor cell, most of them had to undergo lifetime treatment, which include blood transfusion every 15 days, daily iron chelatin infusion, as well as taking lifelong medication to prevent complications from iron overload. Some of medication are deferoxamine, deferriprone, and deferoxamine. Essentially, deferoxamine may be employed for transfusional hemosiderosis and non-transfusion dependent thalassemia. Deferoxamine is typically an iron chelator which works by attaching to iron, which help your body pass the extra iron out into the urine. Therefore, it is used to reduce blood transfusion-related chronic iron overload. Deferoxamine may be taken orally, and its dosage for transfusional hemosiderosis for adults would range from 20 to 40 mg per kg once daily. Meanwhile, the dosage for children aging from 2 to 5 years old would be at 20 mg per kg once daily. Consequently, the dosage for children aging between 5 to 17 years old would be the same as an adult. Next, the dosage for non-transfusion dependent thalassemia in an adult would be at 10 to 20 mg per kg once daily. Meanwhile, a child dose would be at maximum of 10 mg per kg once daily. The Farah syrup is a selective chelator of ferric iron which works to reduce liver iron concentration and serum ferritin level. The Farah syrup is contraindicated in patients with severe hepatic impairment, low platelet count, advanced malignancy, and high-risk myelodysplastic syndromes. However, when current iron chelating therapy is deemed to be inadequate, deferriprone may be employed. It may be taken orally by an adult with a dosage ranging from 25 to 100 mg per kg thrice daily. Deferriprone works by binding with the ferric ion to form neutral ratio of 3 deferriprone to 1 iron complex. However, deferriprone is contraindicated in patients with neutropenia, history of agranulocytosis, pregnancy, and lactation. Lastly, in the case of iron overdose, deferoxamine, which is a heavy metal antagonist, may be employed. Intravenously and subcutaneously, deferoxamine may be given at an initial dose of 500 mg for 8 to 12 hours or up to 24 hours. Then, the usual dose would range from 20 to 60 mg per kg daily, which should be administered from 3 to 7 times a week. Intramuscularly, the initial dose would range from 0.5 to 1 gram daily, while the maintenance dose will be determined by the patient response. Essentially, deferoxamine works by binding to ferric ion to form ferrioxamine, which is a stable complex that can be eliminated via the kidney. However, it contraindicated in patients with severe renal disease or anuria. Other management plans also include keeping vaccination up to date, eating nutritious meals, exercising, and developing positive relationships with their social circle. They should be advised to limit themselves from eating food that is high in iron to avoid iron overload. Genetically, both types of thalassemia are predominantly inherited in an autosomal recessive manner. Therefore, at conception, each child of heterozygote parents has a 25% chance of being affected, a 50% chance of being an asymptomatic carrier, and 25% chance of being unaffected and not a carrier. Despite that, it is also found that such gene mutation may provide a protective effect against malaria. Alpha thalassemia most frequently results from the deletion of one or both alpha gene from the chromosome 16, where the normal complement of 4 functional alpha globin genes may be decreased by 1, 2, 3, or all 4 copies of the genes, explaining the clinical variation and increasing severity of the disease. Meanwhile, in beta thalassemia, the degree of globin chain reduction is determined by the nature of the mutation at the beta globin gene located on chromosome 11. Moving on, by 2020, it is estimated that there are 270 million carriers of mutant alpha globin genes worldwide, making alpha thalassemia as perhaps the most common single gene disorder in the world. Interestingly, 10,000 babies are born with the disorder annually, hence attributing to 10% of the worldwide cases. Meanwhile, beta thalassemia is reported most commonly in Mediterranean, African, and Southeast Asian population, where the prevalence are reported to be at 1.5% of the global population. Next, alpha thalassemia generally occurs in individuals of any ethnic background. However, demographic statistics show that those of Mediterranean, African, Asian, Central American, and Middle Eastern descent are mostly affected among other races. Consequently, beta thalassemia is also reported to be affecting the worldwide population, but its prevalence is mostly dense among Mediterranean, African, and Southeast population. It is also noted that the chances of inheriting this disorder among both genders are equal. Subsequently, those who suffer from thalassemia major may face mortality before the age of 30 due to heart complication, while thalassemia carrier predominantly have a normal life expectancy. As thalassemia is a hereditary disorder, hence if either one of the parent carries the affected genes, then thalassemia trait may be passed down to their offspring in an autosomal recessive manner. As thalassemia disorder does substantially affect one's well-being, we believe the health authorities should be committed to raising public awareness on thalassemia disorder, as it could significantly contribute in preventing and controlling the prevalence of the disease in the society. Consequently, such educational program could assist in increasing public willingness to undergo thalassemia screening and therefore minimizing the pervasiveness of the inherited disorder in the community by identifying the reproduction option between two thalassemia carrier or inheritors. Correlatively, such literacy program may allow people who are living with thalassemia to be more confident in self-managing their health condition while normally pursuing their life. In conclusion, thalassemia is a hereditary genetic disease which can occur to humans of any genders and ages. Thus, effective treatments and management plans have been constructed and employed to increase and improve their life expectancy. Now, let's make a short recap. Thalassemia is an inherited blood disease that affects the hemoglobin production, which can be classified into alpha and beta thalassemia. Accordingly, the treatment option will depend on the severity of their symptoms. This disorder is also known to be prevalent in many parts of the globe and may affect individuals of any genders and ages with affected or carrier parents. That's all from us. Thank you for watching.